So this lecture is about brain injury, and I'm Courtney Cameron. So brain injuries are normally sorted into two different categories, which include traumatic and acquired brain injuries. A traumatic brain injury, or TBI, is defined as an alteration in brain function or other evidence of brain pathology caused by an external force. But an acquired brain injury, or ABI, is an injury to the brain which is not hereditary, congenital, degenerative, or induced by birth trauma. This type of brain injury could be the result of a stroke, near drowning, aneurysm, tumor, infectious disease, or lack of oxygen supply to the brain. But I'm mainly going to focus on TBI, not ABI. Brain injuries are categorized on a qualitative scale from mild to severe. This categorization is based on the extent and nature of the injury, duration of loss of consciousness, post-traumatic amnesia, and severity of confusion during the initial assessment. But there's also the Glasgow Coma Scale, which is used as a scoring system to describe the level of consciousness in a person following a brain injury. It's simple, reliable, and correlates well with the outcome after the brain injury, and it measures functions such as eye-opening, verbal responses, and motor responses. So incidence and prevalence are two different things. Incidence refers to the occurrence, rate, or frequency of a disease. So in other words, the incidence of TBI refers to the number of new cases identified in a specific time period. The TBI incidence data tells us that at least 1.7 million TBIs occur within the US every year, and that those account for 30.5% of all injury-related deaths. However, deaths from TBI have decreased by 7% from 2001 to 2010, which is likely due to factors such as seatbelt use, automobile safety, helmet use, and just better overall treatment for severe TBIs in the hospital. This shouldn't be confused with prevalence, which is the proportion of cases at a given time. So basically, incidence tells us how likely it is that someone will suffer a brain injury, and prevalence tells us how widespread brain injury is within our population. So it's currently estimated that between 3.2 million and 5.3 million people live with long-term disabilities resulting from TBI. However, this number is probably an underestimate since it only counts individuals who have sought treatment for it. The signs and symptoms of traumatic brain injuries vary a lot depending on the severity and the site of the injury, but the signs can pretty much be divided into the 7 categories right here. Physically, you might see loss of consciousness, nausea, vomiting, dizziness, and eventually reduced muscle strength and impairments in motor programming, like those found in apraxia. Auditory symptoms might include hearing loss, hypersensitivity to sounds, or difficulty hearing speech and noise. There also might be neurobehavioral effects, which could include anxiety or depression, mood swings, disordered sleep, impulsivity, or irritability. And the cognitive communication effects and cognitive deficits kind of go hand in hand because an impairment in language can disrupt cognitive processes, and an impairment in cognitive processes can disrupt language. So these symptoms can include difficulty with attention, perception, memory, executive function, and problem solving. These also can impact communication skills, so you might see issues with verbal and nonverbal communication. And similarly, there's language deficits, which include difficulty processing abstract language, difficulty interpreting nonverbal communication, anomia, reduced fluency, and possibly reading and writing difficulties. And then, of course, the motor speech deficits, which would include apraxia and dysarthria. The causes of TBI tend to depend a lot on age and gender, but the CDC has identified the common ones to be motor vehicle crashes, falls, military combat injuries, and sports-related injuries. Car crashes are the leading cause of TBI that result in hospitalization, while falls are the leading cause of TBI among the elderly. So SLPs play a big role in the screening, assessment, and treatment of persons with TBI. The roles of an SLP include providing prevention information to individuals and groups known to be at risk for TBI, screening individuals with TBI for hearing, speech, language, and swallowing difficulties, developing and implementing treatment plans, counseling and providing information to persons with TBI and their families, remaining informed about new TBI research, and advocating for patients, which includes educating other professionals, third-party payers, and legislators about the needs of persons with TBI. So SLPs assess individuals with TBI, but first they need to do a screening to identify possible areas that might have deficits. And before this, a hearing screening is done. And if the patient fails the hearing screening, then the SLP will make a referral for a full audiologic evaluation. Assessment is done to identify and describe strengths and weaknesses in cognitive processing, linguistic processing, and speech reduction. It also looks to identify the presence of dysphagia and the impact of any of these things on quality of life. An assessment usually will involve a case history, a review of auditory, visual, motor, cognitive, and emotional status, and an evaluation of speech subsystems, which would include respiration, phonation, and oral motor mechanisms. SLPs use standardized and non-standardized methods for this, and it generally involves analysis of natural communication samples in different modalities and contexts. And the goal of an assessment is to come to a diagnosis of a speech, language, voice, cognitive communication, and/or swallowing disorder. This should include a description of the severity of the disorders, a prognosis, recommendations for intervention and support, and possibly a referral for other assessments or services. So the goal of TBI intervention is to achieve the highest level of independent function for participation in daily living. Intervention is designed to capitalize on strengths and address weaknesses that affect communication, to assist the person in acquiring new skills and strategies, and to develop and use appropriate communication accommodations. Treatment will typically involve focusing on meaningful outcomes, while also including the individual with TBI in collaborative decision-making, strengthening the person's intact cognitive and communication skills to support intervention, teaching compensatory strategies to the individual and his or her family, practicing with multimodal communication systems, educating patients and families about the nature of their deficits, and measuring progress using systematic methods. So the treatment for cognitive communication impairments will focus either on restoration of skills or compensation for deficits. And this can either be done in a bottom-up fashion, where basic skills build to more complex processing, or a top-down fashion where complex skills are trained to strengthen underlying basic skills. Compensatory strategy training modifies the environment to maximize the skills of the individual, and might include something like memory aids, calendars, or imagery association. There's also computer-assisted treatment, which would be like an app which drills specific skills. There's drill and practice training, which would be like repetitive drills that practice skills to stimulate damaged neural networks. And social communication treatment would involve training everyday communication partners, and it's designed to improve functional communication skills like taking turns and staying on topic. Speech therapy can focus on individual speech subsystems or might focus more globally on overall speech intelligibility. Treatment can be behavioral, instrumental, like electrical stimulation for dysarthria, or compensatory, which might include AAC devices to supplement or replace natural speech. The treatment for dysphagia generally includes compensatory swallowing strategies and diet modification, but it's important to keep in mind that individuals presenting with TBI and dysphagia might have auditory processing and memory loss, which can impact learning and recall, which might make the use of swallow safety strategies more difficult. In conclusion, an estimated 5.3 million Americans live with TBI-related disabilities. The cognitive, emotional, sensory, and motor impairments often permanently alter a person's vocational aspirations and have a profound impact on their social relationships. But SLPs have the opportunity to treat these individuals and help them improve their quality of life.